Okay. All right. So this should be live on Facebook. So once again, good morning, good afternoon, good evening. I'd like to take this opportunity to welcome everyone. My name is, I am Dr. Akwi Asabang, and I am an interventional gastroenterologist. I'm also the co-founder and board president of the Pan-African Organization for Health Education and Research. I am absolutely excited about our session today. We're speaking on a very, very important topic of colorectal cancer. As everyone should know, or we're hoping that by the end of this, everyone will have a sense that colorectal cancer is preventable, it's treatable, and it's beatable. What we're hoping you gain from this session is knowledge. We have a panel of experts from across the globe. So this is your session. Please feel free to ask any questions. But once again, these are medical doctors, but they are not giving you personal medical advice. So at the end of the day, make sure you speak to your own doctor. I will hand over to our co-moderators. We have Dave Nkenge, who is a medical student in Cameroon, and he's also a 2021 Poher Scholar. We also have Dr. Asante. Dr. Comfort Asante is a medical doctor at Dola Teaching Hospital, and she was a 2020 Poher Scholar. So we are very, very excited, and we look forward to hearing the presentations, which are being recorded and live streamed. If the panel, if the attendees have any questions, please use our chat box and the Q&A. So I will hand this over to you, Comfort and Dave. Thank you once again and welcome to everyone. And please mute your mics. Thank you.
Thank you, Dr. Akwi, for that awesome introduction. Good afternoon, good morning, good evening to everybody who has joined us. As we all know, March is the month of colorectal cancer awareness. So our first speaker is Dr. Leolin Kadzira. So just a little bit more about Dr. Leolin. So basically, Dr. Leolin, he's a consultant gastroenterology at Perirenyanta Hospital in Harare, Zimbabwe, and a member of the faculty at the University of Zimbabwe. He did his undergraduate and specialist training in internal medicine at the University of Zimbabwe in Harare, mainly at Perirenyanta and Harare hospitals. He subsequently did a fellowship in gastroenterology at the University of Cape Town and Groote Hospital in Cape Town, South Africa. He did a PhD in genetics and risk of factors of colorectal cancer in African populations. So Dr. Kadzira's main research interests are in colorectal cancer, in inflammatory bowel disease in Africa, and on the interaction between diet, the gut microbe, and also mucosal immunology, colorectal cancer risk. The other thing is Dr. Kadzira is also interested in the development of gastroenterology in Africa. And right about now, he's just going to give us more on the magnitude of the problem. He will talk on the epidemiology and the incidence and factors of colorectal cancer. Dr. Kadzira, to you. Thank you.
Thank you very much for the kind introduction, and good day to everyone who is attending this session, and thank you to the organizers for inviting me. I'm going to talk about the epidemiology, risk factors of colorectal cancer in Africa, really just giving people a teaser, if you would want, of what's to come. So what I'm just showing on the screen is what is known in modern times as Great Zimbabwe, which was built somewhere around the 11th century and is essentially where the name Zimbabwe comes from. My reason for showing this at the very beginning is a lot of my talk is going to be based on the work that we have done on colon cancer in Zimbabwe, and there are lessons for everyone in terms of the epidemiology and magnitude. As we all know, colon cancer traditionally is assumed to be much more common in the Northern Hemisphere, in the industrialized world, so to speak, and much less common in our parts of the world. But we are having an increasing idea that the numbers are rising and rising at a significant rate. When you look at the data from colon cancer and cancer in general, really, is you realize that very few countries have good quality data. Only Uganda, Malawi, Zimbabwe are really considered to have high quality data on colon cancer at the last, according to Global Can. But significantly, this data scarcely covers 10% of the population. And what you can find is the range of colon cancer was ranging from 3.4 there in Malawi up to 9.3 in Zimbabwe. And you can have an overview of what the risk, the incidence is across different countries in across Africa. You can see in South Africa we're 15.6 and 9.5, largely because of the high incidence of colon cancer in the Caucasian population, which comprises a significant part of the South African population. If you then look and you go through what has gone on regarding colon cancer across Africa, what is becoming apparent is that the rates are increasing. There have been reports in Uganda, we have had reports in Kenya, Ghana, and Nigeria. A couple of studies, but these were mainly hospital-based studies. If we look at the data from Zimbabwe, between 1991 and up to 2010, colon cancer increased at about 4% per year. But when you look at Uganda, there wasn't much of an increase on the graph on your right. The question that actually then comes up is, are these true increases, or this is just improved case finding? To answer that, we go back to a study that we published in Cancer Epidemiology a few years ago, where we compared the incidence of colon cancer in Harare between 2003 and 2012. And those graphs shows the age-specific incidence in males and females. And what I always find fascinating about this graph is that there was hardly any change in age-specific incidence between 2003 and 2012, between the ages of up to about 45, 49. But above that, you can see that there has been an increase. This suggests to me that a lot of the increases, if they are happening, are in the older age groups because of changes in their diet and lifestyle, as well as obviously you can't discount the fact that diagnosis is improving. And the other significant thing about colon cancer in Africa, which we have spoken about over and over again, is the high frequency of early onset colon cancer. If you look at studies from different countries in Africa, which we published in a review a few years back, you can see from Nairobi, Kenya, the 11% of their colon cancers were occurring in people under the age of 30, 27% in people under the age of 14. And this really is replicated across different parts of the African continent. And in comparison, just to put matters into perspective, was that in the US, only 0.3% were under the age of 40 and 1.9% were under the age of 0.3 under the age of 30 and 1.9 under the age of 40. This just shows you this in another way. In black there, that's the number of cases in black Africans in a study that when we analyzed data from the Zimbabwe Cancer Registry. And in red, that's the incidence of colon cancer, the number of cases of colon cancer in the white population of Zimbabwe. And you can really see that it really peaks at between 51 to 60 in the black population compared to 70 to 80 in the white population. And when you looked at this data, 25% of our cases were younger than the age of 40. But the question that always comes up is what can explain this? On the left of my screen there, that's actually the population pyramid of Africa, including all of Africa. And it really shows you that the great majority of the population is young. You can see a similar one from Zimbabwe, top right of your corner, where really the majority of the population there, as you can see, is under the age of 50. Beyond 50, there are hardly any people. In contrast, if you look at the bottom right, that's a population pyramid of the white population of Zimbabwe, and it gives you an entirely different picture. So the question that I always had is whether this disproportionate high frequency of colon cancer in young people is just a reflection of the population demographics. And when you just look at colorectal cancer risk in Africa, you then just get the idea, just using this as a scheme of how one might think, that is probably going to be a combination of demographic factors, the age that we spoke about, socioeconomic factors that have a direct link to people's diet, genetics comes into play once people start talking about the early age of onset, smoking, alcohol, comorbidities. And I just mentioned schistosomiasis there because it's one of the things that, in a sense, unique to Africa as well as East Asia. The question that then comes up, just going back to the young age of onset, is whether there is a high frequency of familial colorectal cancer in Africa. We know from previous studies that most of our cancers, there is a significant proportion of cancers with MSI high morphology. There is a significant amount with mismatch repair deficiency. There is a signet ring cell and mucinous histology. These things that I just listed, we know that they are features that are associated with Lynch syndrome. So a couple of years ago, we wanted to actually find out whether there was a high frequency of Lynch in our population. We looked at 90 cases that we comprehensively took their phenotypic data. We managed to get tissue that we checked for mismatch repair protein deficiency. We did MSI in these cases, and we also did MLPA to detect deletions of large genes. And in a selected population, we did next generation sequencing. This data was published last year in PLOS ONE. And what we found is that we found 3 cases of Lynch in 90 unselected population-based cases, and approximately got a prevalence of Lynch syndrome of 3.3% in our population. And adding on to other familial cancers, we got a prevalence of hereditary colorectal cancers of 5.5%. Importantly, these prevalences are really similar to what has been described elsewhere. And the conclusion one may make is that the prevalence of familial colorectal cancers in the African population is actually not any different from what has been described elsewhere. The other question that comes up would be, yes, we know some are familial, but not the great majority, as we have just shown. The question that then comes up is, what are the risk factors of colorectal cancer in African population? This question has a lot of speculation. With very little background data. I think the viewpoint, the world view on risk factors of colon cancer was really, in a sense, affected by the work of Dennis Beckett, who showed, made really the link between diet and colon cancer. But what it did, I think, in a sense, is it gave the impression that there is very little colon cancer in African populations, as well as very little drive for people to look at data as to why those who get colon cancer do get it. But when we did a case control study a few years ago, that was population based, the risk factors of colon cancer that we found were urbanization. Anyone who had ever lived in town and ever lived in town was living in town for at least a year in their lifetime conferred an increased risk of 3.6. Diabetes mellitus conferred an increased risk of colon cancer. Cancer in first degree relatives, which we expect. And then we also found that people who reported having previously had schistosomiasis were also at increased risk of colon cancer. I'm going to duck this question if anyone asks me how, because I don't have the answers. And I think it's fertile ground for research for anyone who is interested. If we then checked to see why is there an association between living in town and colon cancer, what we actually did was to do in the same population, we mapped their dietary patterns and used principal component analysis to try and make associations between dietary patterns and colon cancer. And what we found was that a traditional dietary pattern, i.e., which was dominated by plants, vegetables with very little protein, animal protein, was protective of colorectal cancer with an odds ratio of 0.3%. Interestingly, neither the urbanized diet or the processed food diet that was high in processed foods conferred increased risk of colon cancer in an African population. So really, what you could conclude there was that the traditional diet is protective. Then the question that also comes up is what is the mechanism through which diet confers an increased risk or confers protection against colon cancer? I think increasingly it is being recognized that a lot of the effects of diet is mediated by the impact of the gut microbiota. And we know that diets that are low in carbohydrates, as occurred during urbanization, with high levels of animal protein and fat and artificial foods with less fibers, would lead to a low gut microbiome diversity. Whereas what I would term the traditional type would be hypothesized to lead to a high microbiome diversity, along with the low microbiome diversity would come with a growth of unfavorable type microbiome. Whereas when there is high microbiome diversity, you'd have an increased favorable bacteria such as firmicutes. And we also know that the diet would have an impact on the metabolites produced by this gut microbiome. And we know that short chain fatty acids, particularly butyrate, have anti-inflammatory properties and have been associated with protection against colorectal cancer. Whereas the products of protein fermentation, hydrogen sulfide, and secondary bile acids are said to be detrimental and to increase your risk of colon cancer. So I will just briefly touch on my last bit, which is a study where we looked at the gut microbiota between urbanized Zimbabweans and Zimbabweans in the rural areas. And we really looked at fecal markers of colorectal cancer risk, as well as the diet, and looked at various markers, including microbiota composition, the metabolome profiles, short chain fatty acids, bile acids, and we also quantified the functional microbial genes in these in the two populations. So what we had in terms of diet, when you looked at the urban population versus the rural population was that the only thing that was different was the consumption of animal protein. Otherwise, all the other dietary components were equal, with in terms of animal protein, with much more animal protein in urban populations as compared to rural populations. And but the surprising thing was that there was actually considerable homogeneity when you looked at the microbiota between urban and rural Zimbabweans, with no differences at all in alpha diversity. There was a similar copy number of microbial genes involved in butyrate synthesis as well as removal of hydrogen. There was there were similar levels of fecal butyrate, and paradoxically, the other short chain fatty acids were higher in the urban population. And I think what this does to us is to really cut speculation in the bud and the general assumptions that we would have. But it also shows you that you can't really classify people into urban and rural. There is people are not dichotomous. People, there is considerable interchange between the two places. But interestingly, there were actually subtle differences which are consistent with a heightened risk of neoplasia in the urban residents. Particularly and specifically, there were higher levels of primary and secondary bile acids in the urban population, which can be related to the higher intake of animal protein. And what this shows you, particularly the homogeneity that we found in the gut microbiota between urban and rural Zimbabweans, is that any shifts in the microbiota profile and in markers of colorectal cancer risk is actually a slow, gradual process that I think occurs over generations rather than a sudden change in one generation. And I think this realization that this is a slow process opens up opportunities for prevention, because we can certainly change our diet and we can certainly try to stick to things that protect us from colon cancer. Thank you very much. In conclusion, I will just show you one of the key landmarks of Zimbabwe for you to feast your eyes on, since travel is currently a difficult thing to do. Thank you.
Thank you so much, Dr. Kadzira. That was an amazing and elaborate presentation. For those who are just joining us, this is a discussion on colorectal cancer in Africa. And Dr. Kadzira just took us through the magnitude of the problem in terms of the epidemiology, incidence, and risk factors. Thank you so much. That was an amazing presentation. The next presenter is Professor Olusegun Isaac Aletise. So Professor Olusegun, just a little bit more about him. He has been a professor of surgery at the Faculty of Clinical Sciences, College of Health Sciences in Obafemi Awolowo University in Nigeria. And he is a consultant neurosurgeon at the teaching hospital. His area of interest is in surgical oncology and gastroenterology. He's had his surgical oncology training at the Memorial Sloan Kettering Cancer Center, which is in New York, USA. He has also had other training fellowships in endoscopy and colorectal cancer, colorectal surgery, which was sponsored by the World Gastroenterology Organization. Also, the African Middle East Association of Gastroenterology and Endoscopy. It was also sponsored by the International Council of Coloproctology. He has attended many national and international meetings as a resource person in many national and international organizations in his area of interest. In 2013, Professor Olusegun participated in an African Cancer Leader Institute, and in 2016, he was selected as one of the 50 for 50 upcoming global cancer leaders by International Agency for Research on Cancer, IARC. In 2017, he was awarded the prestigious Prof. T. A. Grillo Excellence in Research Award by his university. Furthermore, on Professor Olusegun, He also co-founded the African Research Group for Oncology in 2013. This group runs a clinical database and biobank for breast and colorectal cancer. He's a leader and a trainer in oncology, gastroenterology in Nigeria. He is the Secretary General of the Society of Gastroenterology and Hepatology in Nigeria. And he's also the Nigerian and also in the Nigerian chapter of International Hepatopancreatobiliary Association. He facilitated the establishment of the routine therapeutic endoscopy, which includes ERCP in Nigeria. Another thing we need to know about Professor Olusegun is he's a member of the Lancet Oncology Commission on Global Cancer Surgery, and also a co-PI on multiple prospective studies on colorectal cancer and breast cancer that have been conducted in Nigeria, including the UG3 and the UH3 NIH grant, which was awarded in 2017, and the R01, as well as the Cancer Prevent grant, which was granted to him in 2020. He has trained over 25 general surgeons who are interested in surgical oncology and have taken faculty positions in Nigeria. He has over 120 publications in peer-reviewed journals and 4 chapters. So Professor Olusegun currently would discuss colorectal cancer screening, the Nigerian experience, organized versus optimistic screening. Professor Olusegun, to you. Thank you, sir.
Yeah, good afternoon, good morning, good evening, everybody. I hope everybody can hear me. Comfort, thank you for the elaborate introduction. And I'm happy to be speaking after the former speaker. The colorectal cancer is not a disease of the West, as has been shown by the previous speaker. It's a disease of everybody now. And what we are Okay, so, and several studies have shown that the incidence is rising in every country. And the only thing that I've shown that can help to reduce the incidence of colorectal cancer is screening. And screening helps us to detect the colorectal cancer early, and it can also help us to detect the precancerous lesion that can be removed, thereby giving us something like a primary prevention. And there are 2 categories of screening modality for colorectal cancer. It can either be opportunistic or it can be organized. Organized screening means that its targeted population is screened. Everybody within the targeted population is evaluated using agreed modality, while opportunity screening occur in the setting where there's an office-based interaction between an healthcare provider and an attendant. Now, there are important characteristics of organized screening strategy, and I've listed them. I'm supposed to speak for 10 minutes, so I want to quickly jump over this, but it must be organized. There must be backed up by policy. There must be a management team responsible for implementation. There must be information technology that backs it up. There's timely access to it, and there must be quality control. The advantage of organized screening is that it provides greater protection from harm for screening, and it ensures that it also prevents poor quality screening. It ensures that everybody that's supposed to be screened are screened adequately and they are given the best of care. And it also offers promise of uniformly delivering screening to all members of the population without leaving anybody behind, especially all the target population. But the problem, the limitation with it is that it requires a functional health system. And of course, it's quite cost involving. There's in Africa, there's no evidence to show that organized screening may be beneficial, may be effective. In low middle income country, we have data from Taiwan and from Thailand, and those data are showing that it may be cost effective. And the only thing we can only do as of up till recently is to adopt some of the findings from those countries. Unlike opportunity screening, which involves setting where patient comes to the hospital Hello?
You can go ahead, Professor. We can hear you.
Okay, yeah, the attending physician interacts with the patient and encourage the patient to go for screening as when due. There are two categories of screening. Of course, we have the biological sample-based test, and we have the colon structure-based imaging, which include flexible colonoscopy, flexible sigmoidoscopy, total colonoscopy. I show these slides to show all the various tests that are available to screen colorectal cancer. And I highlighted those ones that are commonly being used. And in this slide, you will see that there are three main that have been used that is being used in many either organized or opportunistic screening strategy. This include fecal immunochemical testing, which can be done every year or every other year, or combination of FIT plus sigmoidoscopy, and of course, we could also have colonoscopy. This slide shows how some of these modalities are being used. Now, we have done some studies on screening in Nigeria to know what is the best screening modalities that can be used in our setting, especially in sub-Saharan Africa, identifying some of our challenges. Most organizations, most guidelines will recommend FIT for organized opportunity screening in low resource country like ours. But there are potential problems with it because we know that there is endemicity of infective condition in Africa. Could that have an impact on the use of FIT? We also know that our ambient temperature may not be so delightful to the use of FIT. So we evaluated all this in a study, in different studies that we've been conducting for the past 5 years. We've looked at average risk group, we've looked at first degree relative using FIT. We've also done some symptomatic screening, and we are also working on using a urine-based colorectal screening. I'll just give you a snapshot of some of the things we have done. The first study we did was to look at the retrospective stool sample that we collected from patients that had, that we collected sample from for microbiome study. We conducted FIT screening on those patients, and we also checked for oval of parasites. Based on the result, we showed that at least we could pick some that are positive. We went into a feasibility study. I'll give you a snapshot of what the feasibility study looked like. We recruited about 339 patients and participants for a feasibility study. All of them were offered FIT. Only about 80% of, only about 85%, 87% of them return the FIT. And those that returned the FIT screen, we conducted a parasite study on all their stool sample, and we also did a FIT analysis on these two samples. And close to 10% of those samples that were returned were positive for parasites. And then 20% of those that returned the FIT were also positive for FIT. Not all of those patients, the 21%, about 21% of them came for colonoscopy, but we managed to have about close to 19% of them that had colonoscopy done. And of those that had colonoscopy done, our polyp detection rate was 23%, while our adenoma detection rate was less than 10%, which was less compared to what has been reported in developed countries. This slide is showing some of the polyps that we detected. None of them were high grade, and we didn't see any cancer. We felt that probably this is a small study, and though one thing shows clearly that our positive predictive value is low compared to what has been reported in Thailand and Taiwan and some other low middle income country. So that's why we decided to go for a bigger study. Now, not within a community, a multi-site, a multi-state fit study. We started that last year. We recruited about close to 1,200 patients from 4 sites in one state. And by next week, we are moving to another site, another 2 sites within the country. And another 2 weeks, we'll be going to another. So in all, we'll be visiting about 8 different sites within the country, and we'll be recruiting about 3,000 participants. All this one, but for those that we've recruited, our return rate was more than what we had in the pilot study because we included participant navigation. Just to show our result currently, about 20.1 positivity rates we got, and some of the findings is as shown. If all this hold on in other sites, that the positivity rate for FIT is as high as 20%, then we need to check how cost effective will it be, because the number of colonoscopy that we'll still be doing will still be high. Knowing that FIT does not have, it's not being influenced by diet, then we need to find out why are we having high positivity rate. Based on our ambient temperature, what people are suggesting is that there will be high false negativity rate. But currently, what we are finding in Nigeria is high false positivity rate. We done a symptomatic screening because we noticed that most of our patients that had colorectal cancer, majority of them actually had rectal bleeding, and this rectal bleeding has been on for months, and they did not come for treatment. So we came about a study that we can go to the community and identify those that have this rectal bleeding. Can we screen them, conduct colonoscopy in all of them? Will that be able to help us to diagnose colorectal cancer early in some of these patients? So we had 3 sites within the country, and we divided the 3 sites into training sites. Hello, I dropped off a little.
Yes, we can hear you. You can go ahead.
All right. So in the 3 sites, we found that we divided into 2 cohorts. These are patients from family physician that just are presenting with rectal bleeding for more than 1 week. We conducted colonoscopy freely for all of them, and you can see the number of polyps that we found and the number of colorectal cancer that we found in those patients. And we come up with an algorithm that if a patient have rectal bleeding with change in bowel habits and weight loss, the chances for them to develop to have colorectal cancer is very high, and they're supposed to be subjected to colonoscopy. And the interesting thing is that the colorectal cancer that we see, you can see there is a stage migration, meaning that currently in our database, most of our cases, 88% of our cases are stage 3, stage 4. But in those cohorts that develop colorectal cancer from rectal bleeding, we saw that we have quite a number of them having stage 2. We've also looked at the urine metabolites. Can we use it to assess for colorectal cancer? The rationale behind it is that it is easier for a Nigerian to give urine rather than to give feces because of some belief system associated with the use of urine feces. So that's why we were considering, will it be possible to use urine rather than to use feces? And we are working with a group from University of Alberta and Memorial Sloan Kettering Cancer Center. We got about 700 participants, colorectal cancer patients, poly patients, and normal average individual. We send these samples to Alberta and they all run those urine using a mass spectrometry. And the result that we got is being used to develop an handheld device. Of course, the device seems to be useful because we have a sensitivity of 90% and a specificity of 50%. Our aim for developing this device is to reduce the colonoscopy need for those that are coming for screening to less than half. And the machine is going to be like this. It's going to be read out on a smartphone, and we hope by the end of this, by the end of summer, we'll be rolling out the random the RCT using this device in Nigeria. We hope that after this, we'll be able to go to other country in Nigeria in Africa to try the device. Will this be a game changer, helping us to diagnose colorectal cancer early in Africa? Time will tell. So in summary, colorectal cancer is preventable if diagnosed early and can be diagnosed early using screening. If it is, and we've use this in Africa, in Nigeria, all stakeholders must work together to exploit the benefit of screening for CRC in low middle income countries. Various state options are available, but quality and adherence cannot be overemphasized. Best way to spread the news about screening is to start with me. So anyone that is joining this talk, if you have not had a colorectal cancer screening and you are age 45 years, be it male or female, I will advise you to have some form of screening. Thank you. Just to show my friend that we've been doing the study together and to express my appreciation to all our partners that are working with us, our staff and our patients. Thank you.
Wow. Thank you so much, Dr. Olusegun, for that elaborate presentation. It has been so enlightening and also very elaborate and has helped us understand colorectal cancer screening at another level. We look forward to more of your publications. As we have seen, you have so many studies going on, and we look forward to that new method of screening for colorectal cancer. We hope it goes through and we'll have easier methods of screening for colorectal cancer. We are very grateful. Those joining, kindly, if you have any questions for any of the participants, you can add your comments. You can comment rather here on Zoom or on Facebook. Just leave your comments there and the participants will attend to you. The next speaker is Dr. Ahmed Fauzi Salim. So a little bit about Dr. Ahmed Fauzi Salim. He'll give you more, but for now, you need to understand that he's a clinical lecturer of gastroenterology at the Faculty of Medicine at Tanta University in Egypt. So as he begins his discussion on endoscopic management of colorectal polyps, he'll also just tell you a little bit more about himself. Dr. Ahmed, to you, sir.
Thank you very much for nice introduction, and thank you for the invitation. My special thanks to my professor, Professor Mamdouh Gabr and Dr. Mu'min Gabr. Hello, everybody. My topic is endoscopic management of colonic polyps. Colon polyps are protrusion occurring in the colon, most commonly sporadic or maybe the part of other syndromes. They are highly prevalent in the general population, especially with increasing age, and they are an important predisposition to colon cancer. As Professor Olisang said, that polyps are usually asymptomatic and found on routine screening colonoscopy for colorectal cancers. In order to evaluate colonic polyps, investigation needed like CBC or culture blood in stool, and the colonoscopy is the gold standard. In order to choose the best modality to treat a polyp, we must be familiar with Paris classification for the polyp morphology, which classify the lesion either into polypoidal or non-polypoidal. If the lesion has a pedicle or pedunculated lesion, this is 1P. If it is a sessile lesion, it is 1S. For non-polypoidal, maybe 2A, slightly elevated lesion, or flat lesion 2B, or slightly depressed lesion 2C, or excavated lesion 3, non-polypoidal class 3. There are two major classes of colorectal polyps, which are either conventional adenoma or serrated class. Conventional adenoma may be low-grade dysplasia or high-grade dysplasia, either with tubular or tubulovillous or villous component, or serrated class, either hyperplastic polyps or SSP or sessile serrated polyp or sessile serrated adenoma, and traditional serrated adenoma. As regard to the conventional adenoma, the size is of particular importance. Lesions less